This program is brought to you by Emory University.
This is the audience directing the introducer, because when you quieted down, I felt I had to get up here. I didn't know whether that would happen again during the course of our time together. I'm Jeff Copeland, director of the Emory Global Health Institute, and delighted to see a good turnout for a great speaker. So thank you all for coming and sharing part of your weekend with us, and I know you won't be disappointed. The topic today is global health, an aspect of global health, and it's a subject, global health, which has been, is, and will continue to be a hot topic in this country and around the world. Whether your concern is avian influenza in Asia, cholera in Haiti, tobacco use in China, obesity in Mexico, or most of the above in the United States, global health issues can be found daily in our newspapers, and for those of you who stop reading newspapers, on websites and blogs at your favorite computer. No one that I can think of personifies global health and the best leadership in that field than our speaker today, Dr. Srinath Reddy. In his own background, he was born in Chennai, grew up in Hyderabad, of course lives in Delhi now. His parents were professionals, father a lawyer, mother an obstetrician, married to a pediatrician who has become an advocate for the urban poor, has two children who are in young adulthood embarking on their own professional careers, and has a very, very distinguished, productive, contributory professional career himself. Global health involves a quest for equity in health care and for health. Dr. Reddy chairs the high-level group on universal health coverage for India. Global health is concerned about ethics. Dr. Reddy chairs a group on health and human rights for the National Health Commission in India. He's the author and the chair of a recent report which in considerable detail goes into what's needed for universal health care in India. We could use such a report ourselves here. Global health emphasizes a multidisciplinary approach. Dr. Reddy is a star at the top of his field in both clinical medicine and cardiology. He's a star in epidemiology and public health. He excels in scholarship, research, and teaching. He combines academic excellence and public service. As president of the Public Health Foundation of India, he is revolutionizing the field of public health in India through the creation of it as an academic discipline, the creation of several new schools of public health, and creating cohorts of trained individuals to people this field for many years to come. He's the former chair of cardiology at the All India Institute of Medical Sciences, the most distinguished institution, and as a physician, personal physician to the President of India. As such, he's the face of the most sophisticated clinical expertise. He's at home in multiple sites. He has academic affiliations outside of India, in Atlanta, which we're proud of and delighted with, in London, in Cambridge, in Boston, Mass., in Sydney, Australia. In global health circles, he's one of the first names that come to mind on any continent when a high-level committee is formed and you need high-level people to be part of it. He's one of the first names that comes to mind when a special guest lectureship is contemplated, or when a candidate for a major award in public health or cardiology, epidemiology, or clinical medicine is discussed. As such, his CV is filled with a long list of distinguished committees, lectureships, and awards. But besides being a world-class physician and a public health professional, he is a really good and special person, someone you can depend on as a friend who travels 40 hours with no rest to give a talk for a friend in Atlanta, who entertains a visiting friend in Delhi with the 3 hours of free time that he's had all week, but uses it up in his role as a hospitable host. So I present to you a great scientist, a great clinician, a great public health professional, but also a great humanist, a force for public good, world public good, and a great person to count as a friend, Dr. Srinath Reddy.
Thank you, Professor Copeland, for those very kind words of introduction. I'm greatly honored and humbled by this invitation to deliver the Sheth Lecture. It is not merely the debt of gratitude that I owe to the friends in Atlanta who have been not only a source of great inspiration, but of tremendous support to the Public Health Foundation of India over the years, but also the fact that Professor Jagdish Sheth has set up this series of lectures to bring India to the United States and particularly to Atlanta that prompted me to undertake the short journey that I've undertaken here. Anytime you ask me, I'm here. The topic I have chosen today for this Sheth Lecture relates to India, but certainly places it in the context of universal health coverage as a global aspiration. The path to universal health coverage began with the Bismarckian reforms in Germany in 1883, which were principally motivated by the German state wanting to protect the health of its young people so that they could be available for productive occupations as well as for military service. Whatever the reason, the reforms were remarkable at that stage in human history. Then, of course, the beverage model evolved in 1942 during the Second World War and led to the creation of the National Health Service in the United Kingdom. Many other countries have since then evolved their own models of universal health care, partial or complete, but that goal has remained something that has been sought after. But over the last 2 decades, we have seen many of the developing countries of the world, the low and middle income countries of the world, also moving very rapidly and with great determination towards this goal of providing universal health coverage to all of their people. Whatever the level of health care, they felt equity and universal access were important issues. And we find resonance of that and good reporting of that in the World Health Report of 2010, which is actually titled Health Systems Financing, but lays out the framework for universal health coverage. We have had Mexico declaring 100% coverage of its population by the end of last year. We have China attaining 95% coverage of its population through 3 major insurance schemes, mostly government or employer funded, last year, and aiming towards 100% coverage this year. We have South Africa again attempting to reach 100% coverage this year or next. Where does this leave another major country, India? I believe India is attempting to embark upon this path with determination this year, though we recognize the attainment of universal health coverage in its complete form is an evolutionary process, never an overnight event, and this might take a decade or 2. But if India does indeed accomplish this, even within the next 10 years, that will be a remarkable feat. The question, therefore, I would pose today is whether India can realistically attain this and what are the steps it needs to take it. The 21st century has been described as the Chindian century, and this is something that has been featured in a Time cover story in November. Ignore Berlusconi there on the cover, actually, but it's India that actually comes up as the major source of the story in the text. And while comparing the Chinese and Indian models of development, one of the authors actually states that India probably has a better chance to succeed than China because it is a freer democracy, and therefore the likelihood of development in an unfettered manner is much more assured in India. While this is certainly flattering, and we believe this might be true, at the moment, in terms of health indicators, we do have a much leeway to make up when we look at not only China, but a number of other developing countries. Before we talk about why India requires universal health coverage and what it needs to do about it, we have to clearly understand the failings of the Indian health system. And we have to be candid about that and acknowledge some of these shortcomings. After all, India's national bird is the peacock and not the ostrich. So when we look at the key health indicators, India's infant mortality rate was 50 when China's was 17 and Sri Lanka's was 13. The percentage of children who are fully immunized was 66% in India, when Sri Lanka, even at the height of its civil conflict, had 99% coverage. So whatever the health indicators, the lag is very clearly evident. When you look at the current health scenario, India has the largest number of underweight children, 42% under 5 years, recently reported in a nationwide survey, which the Prime Minister of India described as a national shame. The current infant mortality rate, which is absolutely current, is about 47 per 1,000 live births. The maternal mortality ratio is 212 per 100,000 live births. And these are well short of the national goals that we've set for ourselves, either for 2015 through the Millennium Development Goals or through the Indian Plan Period goals for 2017. At the same time, we find that there is a huge rising burden of non-communicable diseases, which is challenging an under-resourced health system. India has about 61 million persons with diabetes now, likely to rise to about 101 million by 2030. The number of persons with clinical hypertension is likely to move up from 130 million to 240. The number of persons with tobacco-related deaths is likely to rise from about 1 million plus now to about 2 million plus. And when we look at cardiovascular deaths, which are occurring prematurely, with Indians being particularly vulnerable to early onset of disease and early death, with about a decade earlier advent of the first myocardial infarction at the age of 50, at least a decade or so earlier than in the Western countries. We find that the potentially productive years of life lost because of premature cardiovascular deaths in the age group of 35 to 64 were 9.2 million in year 2000 and will rise to about 18 million by 2030, more than that in China, which has a larger population. But when you compare it with the United States of America, it was about 570% more in 2000, and it will be 900% more in year 2030 in that age group. No country which aspires for accelerated economic growth and positions itself as an economic power of the 21st century can afford such a hemorrhaging of human resources in the productive prime of midlife. At the same time, we recognize that there is a huge disparity in health states across the Indian states, with a girl baby born in Madhya Pradesh 6 times more likely to die before her first birthday than a girl baby born in Kerala. At the same time, neonatal mortality rate varies from 11 per 1,000 to 53 per 1,000 in Odisha. And these inequalities are reflected across not only urban-rural differences, but also different income strata, educational strata, gender, and caste. So when we are looking at young India, and India hosts the largest number of young people in the world now, and has the demographic window of opportunity for accelerated economic growth for at least the next 2 to 3 decades. And India is therefore likely to be seen not only as the source of its own workforce, but a source of global workforce. The concerns are that we do have 42% of our children underweight, but at the same time, 24 to 32% of urban adolescents are overweight or obese in middle-income families, and 15% overall urban obesity rates in children. Therefore, we need health and nutrition programs that reduce both forms of malnutrition. While India, as I said, has a high and rising burden of diabetes, it still has a third of the world's measles deaths and tuberculosis patients. Therefore, we need a healthcare system that can tackle both the diseases of underdevelopment as well as the disorders of maladapted modernity. But when we look at the question of why health system reform is urgently needed in India, I think some of the data come from the National Sample Survey of 2004, reported in 2006, where it suggests that 28% of rural residents and 20% of urban residents had no funds for health care. This figure had doubled over 2 decades. Over 40% of hospitalized persons had to borrow money or sell assets to pay for their care. And over 35% of hospitalized persons fell below poverty line because of hospital expenses. And the reason for this becomes fairly clear when you look at the proportion of public financing that goes in for health. While India has a fairly large amount of public financing for a variety of causes, and indeed, the overall envelope of public financing compares much better than Sri Lanka, China, or Thailand, the proportion of public financing that goes into health is much lower than of other countries, and therefore, public financing or public expenditure on health as a percentage of GDP is much lower than these comparator countries. And this is also seen whether you look at it in terms of per capita total expenditure on health. While the total expenditure on health as a percentage of GDP compares fairly well, when you look at the per capita total expenditure, the differences show up. But even more than the per capita expenditure on health, it is the per capita public expenditure on health which is much lower, and this shows up very starkly. And right now, the Planning Commission, in its latest report, puts the public expenditure on health even at 1% of the GDP. Most of the last 2 decades, it's been stagnant at 0.9%. It had moved up to 1.2%, and current estimate is 1%. And there are also large interstate differentials in public spending. If you look at Bihar and Kerala, Bihar spends about a third of the money spent by Kerala in terms of public financing. And if you look at the other side of the picture and look at the proportion of children fully immunized, then you can see the difference, Kerala performing much better than Bihar. Tamil Nadu performs better than even predicted by its level of public financing because of a much sturdier and robust public health system. Uttar Pradesh performs worse than predicted based on its public financing because of poor governance. Now, if you look at high out-of-pocket expenditures, which is one of the critical elements when we look at health financing, then India is among the countries with almost the highest level of out-of-pocket expenditure. Currently, it's estimated to be about 71%. For most of the last 2 decades, it used to be around 78 to 80%. Most other countries have it below 50%. And if you look at the contributors to this out-of-pocket expenditure, then you see that outpatient care substantially contributes to about 3/4 of out-of-pocket expenditure, and medicines in particular contribute to a very large fraction of out-of-pocket expenditure. And if you look at impoverishment due to out-of-pocket payments in India, then it's estimated that about 40 million, 39 to 40 million persons are pushed into poverty each year because of unaffordable healthcare costs. And the current schemes that exist for financial protection mostly do not cover outpatient care or drugs or lab diagnostics, which collectively contribute to the larger fraction of out-of-pocket expenditure. We do have government schemes that have been introduced in order to try and reduce the health burden and provide financial protection. The Rashtriya Swasthya Bima Yojana, or the National Health Insurance Fund, which was started a few years ago, essentially was meant to provide protection for below poverty line families, especially those in the unorganized sector, and provides protection even for migrant workers. It has had rapid enrollment and expanding coverage. It is portable, as I said, across the country. It has successfully brought in public and private providers for secondary care. Some levels of quality improvement have been brought in. There's been a very effective use of information technology, both for enrollment as well as follow-up, and fraud detection systems have been improved. However, this scheme, well-intentioned as it is, and partially successful as it is, only covers hospitalized secondary care. There is a neglect of preventive and promotive care. And if the utilization rate is very high, example in Kerala, then the scheme becomes financially non-sustainable. Over the last 3 years, the insurance provider who is managing the scheme as a third-party payer, though the government is putting in most of the money, has been escalating the costs each year and saying that otherwise it's becoming impossible because of the high claims ratios. And the argument given by the insurance provider is people in Kerala are very educated, they have high expectations of health. God forbid if the rest of India becomes educated to the same level. So there is also a cost escalation because there is a fee for service. This is not a capitation system. Therefore, there is really no true containment of costs. And a recent study by some of my colleagues has shown a paradoxical rise in out-of-pocket expenditure. Well-intentioned as this is, this covers only hospitalization costs and drugs during hospitalization. But having unmasked a disease and conducted a procedure which often requires lifelong treatment or at least prolonged treatment post-hospitalization, if that period is not covered, then the out-of-pocket expenditure actually rises in a paradoxical way. The impact on overall health outcomes is questionable, but also worrisome is the fragmentation of care or lack of continuum of care. What we would like to see in an ideal health system is a good linkage between primary, secondary, and tertiary care services. That does not exist because the focus here is only on secondary care. At the same time, in state-level programs, we see a number of programs that have come up in the recent years in which the state governments have initiated programs for covering poor people and providing them access to tertiary care, mostly in private hospitals, but also in government facilities. And these have often slightly higher coverage than the Rashtriya Swasthya Bima Yojana, which covers only up to $600 per family per year. These go up to about $3,000 per family per year. But they also cover hospitalized tertiary care. And because most of the state health budget is now being diverted to this, in states like Andhra Pradesh and Tamil Nadu, the proportion of state health budget which goes into tertiary care is now about 50 to 55%. And this leads to a neglect of both primary care and of public facilities. And there's a high level of induced demand and inappropriate care because of lack of appropriate gatekeeping functions. In terms of private insurance markets, private insurance coverage remains low, with financial protection again available only for hospitalization and not for outpatient care. India's medical insurance system remains weak and fragmented. Less than 1 in 10 families get coverage through that system. The benefits of traditional insurance coverage accrue only to a privileged few and those working in the organized sector where employers provide that coverage. At the same time, we must recognize that India is a federal polity where state governments are primarily charged with providing health care. And they bear close to 2/3 of the total government health expenditure. The central government accounts for the remaining third. Though the central government's financial contribution is relatively small, its influence is substantial because it funds some of the national programs, especially those that go into primary health care. And the National Rural Health Mission has been particularly a wonderful example of the central government's mission for advancing health care. At the same time, we have seen that access to medicines has decreased in terms of free supply of medicines. In comparison to 1986-87 to 2004, the proportion of free medicines provided has substantially decreased, both in inpatient as well as in outpatient settings. At the same time, between 1980 and 1993, because of changes in the price control policy, the price of drugs increased by 197%. So the drugs have become costlier, though India does produce generic drugs in large quantities and supplies many countries in the world, and we are indeed considered the pharmacy of the South and even of the globe. Nevertheless, in terms of affordability within the Indian context, prices still remain a challenge. At the same time, the number of beds available in hospitals for hospitalization care are much fewer than the global norm of about 2.9 per thousand. Even assuming that as we advance towards more of day care, less of hospitalized care, even then, we need to reach at least about 2 beds per thousand if we need to address some of our healthcare needs. Our health worker availability is extremely low in some of the North Indian states and in the Northeast. Indeed, India has been classified by WHO as one of the countries facing a global health workforce crisis. As opposed to the global norm of about 23 to 25 health workers, that means doctors, nurses, and auxiliary nurse midwives per 10,000 population, we have 13 per 10,000. And even these are maldistributed. About 80% of the doctors, 75% of dispensaries, and 60% of hospitals are located in urban areas. And when you look at qualified physicians, you see the glaring difference between availability in urban areas and rural areas. But things have not been so dark in the recent years. There has been a determination on part of the government of India to try and redress this. The National Rural Health Mission was launched in 2005, but actually began to roll out in 2007. And in its first phase, which ends this year, the focus was on maternal and child health. Each village now has an accredited social health activist, or ASHA. ASHA in Indian languages means hope, who are responsible for mobilizing women for institutional deliveries, children for immunization coverage, and other facilitation of health programs. Conditional cash transfers were introduced through the Janani Suraksha Yojana, or the Safe Motherhood Program, for promoting institutional deliveries. There has been infrastructure strengthening of primary healthcare centers. There's been increased fund flow to states with flexible funding mechanisms, much greater decentralization of planning with move towards district-level planning, and in fact, block-level and village-level planning. And the mission also becomes a platform for progressive integration of multiple national health programs, which hitherto have remained vertical and fragmented. But despite the National Rural Health Mission, deficiencies continue, and we need to now look at a framework which unifies the social objectives of the Rashtriya Swasthya Bima Yojana, or the National Health Insurance Scheme, and the National Rural Health Mission into a much more sustainable and comprehensive framework of universal health coverage. It is with this intent that the Planning Commission of India constituted a high-level expert group on universal health coverage, which I was privileged to chair. We were given 8 months. We were set up in October 2010, and we were given 8 months. We took about a year to complete this, and none of us were full-time involved in it. But nevertheless, we were asked to address healthcare financing as the main issue, but recognizing that an entitlement that is conferred by whatever financial mechanism will not get translated into delivery if the human workforce, human resources are poor, if the infrastructure is poor, if the management systems are poorly functioning, if the community is not empowered. Our mandate involved also a blueprint for human resource requirements for 2020, management reforms, the physical and financial norms for health facilities, a plan for providing access to affordable medicines, and essentially we were asked to develop a much more comprehensive package. The social determinants of health were not originally included, but our own group decided to bring it in because, as the Nobel laureate Swedish economist Gunnar Myrdal said, health leaps out of science and draws nourishment from the society around it. We recognize that policies and programs in other sectors which are conventionally regarded as outside of health, have a far more profound impact on determining health of societies than actions within the health sector itself. So we decided we must look at things like water, sanitation, nutrition, environment, and all of these are so pertinent to the area of health. So our definition of universal health coverage was to ensure equitable access for all Indian citizens to affordable, accountable, and appropriate assured quality health services, as well as public health services addressing the wider determinants of health, with the government being the guarantor and the enabler, although not necessarily the only provider of health and related services. So we put the state forefront as being responsible, but not necessarily being the sole provider. There's a greater opportunity for the private and voluntary sectors to collaborate with the public sector in providing these services. And we decided to look beyond the traditional insurance system. What we are looking for is not health insurance, but health assurance. So our vision is universal health entitlement for every citizen to a national health package of essential primary, secondary, and tertiary healthcare services that will be funded by the government. And the package will be defined periodically by an expert group, and which will have state-specific variations. This entitlement guarantees an individual citizen to essential health package, including cashless inpatient and outpatient care free of cost through a single-payer system based on a capitation system rather than a fee-for-service. And this will include all of primary care, all of secondary care, and some elements of tertiary care. The question was asked, why do you want to include tertiary care? I mean, should not people pay for it themselves? Why should it be part of an essential health package? How do you tell a young snakebite victim in rural India that he is not entitled to ventilatory support when he requires it to recover his life? How do you tell a young mother whose pregnancy has been mishandled that she should not have tertiary care for treatment of a ruptured uterus or a vesicovaginal fistula? So we believe there are certain elements that must be brought in even under tertiary care. But they will have a choice of facilities. The people will be free to choose between the public sector and the contracted and private sector facilities. How do we finance the universal health coverage? Firstly, to ensure sufficient financial resources to provide essential health care for all, to ensure financial protection, and provide health security against impoverishment. The huge out-of-pocket expenditure must come down from 71% to less than 50% and progressively to 30% or so. And to put in place financing mechanisms that are consistent with improved well-being as well as the containment of healthcare cost inflation. We know how healthcare costs have affected this country. There was a period in America when it was being said that General Motors was mainly a healthcare business with automobile manufacture as an ancillary. So we would not like that kind of a situation to be visited elsewhere. So in terms of our recommendation, we believe that the government funding should increase the public expenditure on health from the current level of 1.2% of our GDP to at least 2.5% by the end of the 12th plan and to at least 3% of GDP by 2022. We did a fair amount of calculations for this. And interestingly, another recent independent study, which just came out in PLOS One, also comes somewhere close to this. This figure estimates that it would be about 1,700 rupees per person per annum in India. This cost would be 24% higher if branded drugs are used. Extrapolation of these costs to the entire country means that the Indian government needs to spend 3.8% of the GDP for universalizing healthcare services. They took the GDP as relatively static. We took the GDP as growing, and it will continue to grow, in which case the figure of 3% would probably be there in both the calculations. Now, if you look at the second recommendation is to increase in the public procurement of medicines from about 0.1% to about 0.5% of GDP. If the out-of-pocket expenditure is substantially dictated by the cost on medicines, then clearly providing essential drugs free of cost would provide a great deal of relief to the people. This is something that can be achieved in a relatively short term, even as health workforce is being expanded, infrastructure is being strengthened, and financial protection mechanisms are being evolved in terms of essential health package. And we have models which have succeeded, like the Tamil Nadu Medical Systems Corporation in Tamil Nadu has shown over the last 2 decades how effectively they can be centralized, very transparent, pooled procurement, which has drastically cut down the costs of drug procurement. And with each district having its own warehouse, there is decentralized distribution, very little stockouts, and public facilities in primary and secondary care are providing all the essential drugs. So we have models for replication in India. And expenditure on primary health care, we said, should account for at least 70% of all healthcare expenditure and cover general health information and promotion, curative services at the primary level, and screening for risk factors at the population level. If primary health care is adequately promoted, the referral for secondary and tertiary services, the demand for those services would be reduced as well. We suggested that general taxation should be used as the principal source of healthcare financing, complemented by additional mandatory deductions from salaried individuals and taxpayers, either as a proportion of taxable income or as a proportion of salary. Why not contributory social insurance? It will not work in India because it is a huge unorganized sector. Payroll taxes are not going to work. So we have to have tax-based financing, and this is a consensus that most international experts have also supported us in. In terms of providing some additional taxation on individuals with higher incomes, I was greatly heartened by listening to an interview of George Soros this afternoon on CNN IBN, that he too believes that people with higher incomes should be taxed a little more and contribute to social solidarity. I know Warren Buffett said the same thing. The 5th recommendation is do not levy user fee of any kind, because user fee has been demonstrated since the prescription by the World Bank and IMF in the 80s and early 90s. It became part of the policy in many low and middle income countries. But global experience has now demonstrated, not only in Africa but in other countries as well, that user fee is counterproductive, and even the World Bank has now begun to revise its stand. User fee is inadequate in terms of the amount of resources it raises, inefficient because it requires a huge administrative machinery to identify who is poor and not poor and so on and so forth for exemptions, and highly inequitable because it denies poor access to services, and this has been repeatedly demonstrated. And there's been negative impact on the usage of health services, even from those that need them most. Margaret Chan, the Director General of WHO, said, this did not happen. That is, the overconsumption of care, which user fee was supposed to limit, did not happen. Instead, user fee punished the poor. And Jeff Sachs says, from his experience in Africa now, that among the quick win strategies recommended by the Millennium Project in Africa, which he's leading, was the removal of user fee from primary education and essential health care by the end of 2006. So not merely public health experts, but economists now believe that user fee is something that should be eliminated from the health services. What we are suggesting is that the universal health coverage package of essential health services, which will be the national health package with the India health card or something like that, would be available free of cost, cashless, and would not have any user fee, as I said. However, there are additional elements which could have financing from out-of-pocket expenditure or private insurance. They could involve hospitality components like private ward beds, or people who opt for hospitals who are not part of the UHC system, or additional services which are not covered in the essential health package. It does not mean that the poor will not benefit from some targeted programs. Why is it that we are insisting on universality rather than targeted programs as in the past? Because it has been repeatedly demonstrated that programs meant only for the poor are poor programs in design as well as in delivery, because the rest of the society does not have a stake in them, and they will continue to falter. So we said universality is absolutely essential if everybody has to have a stake in the success and sustainability of a universal health coverage system. But that does not mean that the poor may not be entitled to some of the targeted programs from the package of services not included in the essential health package. Do not go the insurance route. All government-funded insurance schemes should over time be integrated with universal health coverage, and the purchase should be directly undertaken by agencies linked to the government, even if they're autonomous agencies at the central and state level. Again, this may be open to challenge, but let me support myself by quoting Bill Shaw from Harvard, who incidentally I think is currently guiding the healthcare program in Vermont, but Vermont is possibly an outlier in the American system. But anyway, what he says is insurance cannot achieve social equity, and that serious market failures allow insurance to practice risk selection, leaving the most vulnerable people uninsured. Adverse selection among insurance buyers impairs the functions of the insurance market and deters the pooling of health risks widely. Moreover, the insurance market's high transaction costs yield highly inefficient results. So in terms of tax financing and going through a non-insurance route, we believe the universal health coverage package in India should be protected. We also are suggesting that because states like Bihar have much greater health needs and their level of financing is low, additional allocations should be made to such states, of course, insisting on performance and accountability and deliverables. So flexible and differential norms for allocating finances so that states can respond better to differentials and diversities across districts. In terms of provision of health care, we are suggesting strengthening of public services, especially primary health care, both in rural and urban areas, and district hospitals, which have been previously neglected. Our belief is that if we do this, 90% of the healthcare problems of a district can be taken care of up to the district hospital level with very little spillover required for going to tertiary care hospitals. We are also suggesting contracting private care providers, but as per need and availability, to be defined by the district health system manager. But to integrate primary, secondary, and tertiary care services through networks of providers. No longer can we afford fragmentation. So whether it's a public provider or a private provider, they should try and network the individual healthcare providers and from the primary care and also the facilities from secondary care so that a good referral and follow-up system is established and some gatekeeping function is exercised with clearly defined deliverables for each package of services for which they've been contracted. So we are talking about providing essential and standard health services, more functional beds, quality assurance. In terms of human resources for health, we are talking about increasing the numbers and skills of frontline workers, placing emphasis on non-physician healthcare providers. We do require more doctors. We do require more specialist physicians as well. But at least in the early stage, for primary healthcare, we require many more non-physician healthcare providers, especially nurses and multipurpose health workers and so on, and mid-level health workers. We are asking for new medical colleges and nursing colleges to be established in the underserved states and districts. At the moment, most of the medical colleges in India and the nursing colleges are concentrated in 4 southern Indian states and in Maharashtra in the west. The rest of the north have very few colleges. We are suggesting that the number of and quality of allied health professionals, that is the paramedics, should be also increased, and to establish district health knowledge institutes to coordinate all the training of these various cadres at the district hospital level. And we have projected, based on the kind of institutions that we believe should be established over the next 2 planned periods, that we will reach the desirable norms by 3 planned periods, because it will take a little time for the graduates of these new schools to come out. We are asking in terms of management reforms for a national health regulatory and development authority to be set up at the central level to support the universal health coverage system through standard treatment guidelines, management protocols, quality assurance methods, legal and financial and regulatory norms, and management information systems. At the same time, supported by accreditation norms through a registry and national registry, and also an independent monitoring and evaluation unit for the national health programs, because right now, most of our programs are not evaluated. They will have their counterparts in the state, and we will be linking up the national agency with the state-level agency. We believe that community participation and citizen engagement are absolutely critical. And here we are drawing inspiration from some of the models which have been validated elsewhere, like the village, district level, and national level health councils, which have performed very well in Brazil. organize regular health assemblies annually, like in Thailand, strengthen the local government bodies like the Panchayat Raj institutions and the municipal local bodies, strengthen the role of the civil society overall, and institute a formal grievance redressal mechanism at the block level through an ombudsman. We believe that the social determinants of health are very important, and we must take several initiatives to ensure that some of the social determinants are also advanced simultaneously by setting up integrated social determinants committees looking at education, health, sanitation, water, and all of them as an integrated package at district, state, and national level. We are asking for a National Health Promotion and Protection Trust to be set up both for health communication as well as health impact assessment of policies in other sectors. We are asking for all of this to be evaluated through a comprehensive national health equity surveillance framework with an equity metric also being applied to the delivery of health services. As I said, Gunnar Myrdal had already been quoted that the social determinants are very critical. So we are suggesting that policies and programs in a variety of sectors, which apparently are unrelated to health, but do have a profound impact on health, also need to become sensitive and responsive to public health concerns. So what are the challenges to universal health coverage? Clearly, there are political challenges because health is a state subject, and therefore center-state relations become very important in this area. This package has to be negotiated carefully with the states. They have to see not only they're deriving an advantage for their people, but also have to be reassured that their autonomy is not being infringed upon. The fiscal space, do we have the money to deal with this? I think even with 7% growth rates that we are talking about now, we will have the ability to increase. And the Planning Commission of India has already announced that there will be at a minimum 2% of public financing, of the 2% of the GDP public financing in the 12th plan period. They will try to go up to 2.5%, but 2% is a given guarantee. We also need multiple party consensus in a country with several parties in power, not only at the center, but also in the states. The capacity of the health ministry and the public sector have been challenged. You have put so much responsibility on the public sector. Can a weak, inefficient government department really deliver all of this? We believe we need to strengthen the capacity of our public sector, and Tamil Nadu has already shown the model. The National Rural Health Mission has shown the model, and if we actually invest our resources adequately in strengthening the public sector and wisely drawing upon the other sectors as well, it can be done. Human resources will continue to be a challenge, and it will take about 3 decades at least for us to really achieve that level of self-sufficiency. But in about 15 years, we'll reach reasonable levels of self-sufficiency. What about the commercial interests who will oppose it? Private insurance is not going to like it one bit because they are going to be phased out of this particular part of it, but they can take other pieces which are not covered under the universal health coverage scheme. What about the big pharma? Will they like price control? Will they like centralized procurement of drugs which are either unbranded or branded generics? Obviously, if the government of India is going to spend 0.5% of its GDP on buying drugs, there is a volume from which even other drug companies can derive profit. The margins will come down, but the volume will expand. So if they see the writing on the wall, they will go in for tiered pricing in a high-volume market like India. Private healthcare providers, will they be antagonized? If they can be coming in to a contracted-in mechanism and are given a place in the larger framework of universal health coverage, we do not see major opposition from them. So, to conclude, there are several advantages we have to offer in terms of universal health coverage to make this politically saleable. We are appealing to greater equity. We are talking about improved health outcomes. We are talking about financial protection for the people. We are talking about efficient, accountable, and transparent health system being established. We are talking about reduced poverty, greater productivity. But in an economy which is challenged globally and is desperately looking at job increase, and I've been heartened to read about the job increase in this country recently, but even we too would like to increase jobs because we have a young and expanding young population, and we would like them to get into the job market. The health workforce offers one of the best avenues for expanding the job market, not only for doctors, but for non-physician healthcare providers, for the young people and women to be empowered and brought into the employment job market. The health workforce expansion provides the best avenue for India. And therefore, I think that's an attractive proposition for the politicians, for the economists, for the finance minister. And this is something that we're going to sell to them. As Toni Morrison said, if we don't create the future, the present extends itself. I believe the present is a very unsatisfactory state. We do need to create the future, and we do have some hope of doing so. Thank you. I'll be happy to take some questions or some comments from the floor. Professor Jeff Copeland will moderate it when required, if required. But there are 2 mics, I believe, on the floor. So if any of you wish to direct any questions or comments, you may proceed to the mics. And
Hi, I wondered if you could expand a little bit on the idea that it'll be easier for a democracy like India to achieve this than it would be for a country like China. Thank you.
well, I think that was actually meant in the context of development, and I would advise you to read the Time magazine because there were 2 different viewpoints, opposing viewpoints expressed, because there was one viewpoint expressed by the votary for China that because they have a command economy where the state exercises great control and has the ability to speed up things, China is going to have a definite edge over India. The counter-argument put forth was that India, being a much more democratic society, is likely to build in greater consensus among its people, and therefore is likely to be more steadfast, even if initially slower, in its developmental path. But as far as health is concerned, I can assure you that India, as a noisy democracy, has great advantages. We have now a right to education. We have a right to information, which is very actively exercised. We have the right to food now being enacted. Therefore, given this rights framework, a very vibrant civil society, a very participatory democracy with a few flaws here and there, but nevertheless a very participatory democracy, I believe we have the ability to demand of our policymakers that such a system be established and such a system be run well. We have had a neglect of health over the last several decades, but I don't think that's going to be the state of affairs in the coming years.
Thanks for a very informative lecture. While India, as you recognized, is the pharmacy of the world, it is also an IT capital of the world. So what are the plans within this initiative for the electronic record management and sharing, and what would be the future for using those systems in place?
Well, we have actually devoted a fair amount of space in our report to the entire IT infrastructure as a backbone for the system. Fortunately, the Rashtriya Swasthya Bima Yojana has established a good model of how IT can be effectively utilized for this, and we believe that platform must be utilized much more. I think bringing in IT much more effectively not only increases the efficiency of the system, but also transparency of the system, and we'll utilize IT much more effectively. The draft chapter on health for the 12th plan, prepared by the Planning Commission, has a complete chapter on IT. And we believe that not only in terms of delivery of services, but creation of electronic health records, of efficiently building up health management information systems, India's advantage in IT would be of great help.
Srinath, that was a lovely talk. You didn't mention anything about research and the research agenda. And also, if you look at China and India, there's been in China a tremendous prolongation of life in the last 5 decades or so, about 8 years per decade in China and about 6 years per decade in India, all of that without much direct investment in health. So when you think about selling this plan and getting buy-in, what is the return on investment that you see, the health investment, as opposed to investments in education or in other social norms?
As far as research is concerned, we did make recommendations for establishing stronger research networks as well as building even new research institutions. Because we recognize that knowledge generation is important, but also knowledge translation in terms of operational research or health systems research or implementation science, whatever you want to call it. So we have actually asked for a fillip to be given to that, and indeed the Planning Commission in its own 12th plan document reflects that fairly clearly. Obviously, our recommendation is much more geared to how delivery of services can be improved through health system innovations, which can be designed and evaluated through research, rather than high-end biomedical research. But even that is not going to be neglected. Now, in terms of the life expectancy, certainly we have had some creditable gains in life expectancy, but they could have been much higher. But I think what is most shocking and saddening is the inequality in health between different states and different sections of our society. And it is that inequality that needs to be bridged. It is that barrier to affordable health care or access to health care, which frequently limits people from accessing very essential health services, that needs to be removed. And therefore, the return from our point of view is that more people should be able to access services without barriers. The quality of those services must be appropriate, and the impoverishing effect of undergoing treatment, which is now reflected in a very high out-of-pocket expenditure, must be brought down. Those are the kind of metrics that we'll be looking at.
Thanks, Dr. Reddy. So the way you define universal health coverage, you use the term government is going to be both the guarantor and the enabler. And so referring to this inequity that you just mentioned, how do you see government's role playing out in an urban India versus a rural India? Because it seems that the state of public health is probably quite different in those two different regions. And this question also sort of bears in mind the current debate that we see in this country on regulation versus competition in the healthcare system.
Well, as far as rural India and urban India differences are concerned, even in urban India, while there is a greater availability and concentration of doctors and other healthcare providers, primary healthcare services are still in a state of neglect. While in the initial stages, primary healthcare was designed as a system, as a health system feature only for rural areas, with the naive assumption that urban areas will have enough facilities to take care of people in urban areas. We now recognize that firstly, the urban poor are still marginalized in terms of access to health. Affordability continues to be a barrier to them as well. But equally importantly, in the absence of well-designed primary healthcare services in the urban areas, you have an undue demand and overflooding of secondary and tertiary care facilities, which is a very inefficient use of resources. So we believe that urban primary healthcare, secondary healthcare, and tertiary healthcare must be now built into a system design which is well integrated. And financial protection must extend to all citizens whether living in rural or urban areas. So even the government of India is thinking of a national urban health mission and possibly merging the two into a national health mission. That still remains to be seen in terms of the calendar. But this is bound to happen. And ultimately, we believe that there will be one unified health system. The second question that you sort of asked as a corollary was related to, you said reservation versus competition. Regulation versus competition. Well, we are suggesting, unfortunately, the health sector has been one of the most unregulated in India. It's been totally laissez-faire. Now, we do need to bring in some degree of regulation in terms of cost and quality into the health sector, because we know it's an imperfect market. We know there's a tremendous asymmetry of information and decision-making power between the healthcare provider and the person who is seeking health care. So regulation becomes mandatory in case of to correct the market distortion. But we are still permitting competition in this, because we are bringing in contracted and private providers, we are bringing in public facilities. They can bid for, as a network, they can bid for services, because the district health system manager will decide how these services will have to be delivered. So there is still an opportunity for competition within the system. We are not removing choice, but we are bringing in much more cohesion into the system.
Thank you for your talk, Dr. Reddy. I was just wondering about how you would determine what services would be covered in your the national health package. Would you have panels looking at evidence-based services that would be covered versus sort of a free-for-all?
Well, that's an excellent question. We did decide that all of primary health care would be covered, even all of secondary health care would be covered, like in some of the current insurance programs. The tertiary care would probably have a negative list rather than a positive list, but we'll be certainly looking at establishment of guidelines based upon not only disease prevalence, the kind of healthcare needs that are reported in terms of the demands, but also what would be cost-effective use of resources. We are looking at the establishment of a NICE-like institution. The Health Development and Regulatory Authority that we are talking about would have a NICE-like institution also as a component. For those who are not familiar with NICE, this is the National Institute of Clinical Effectiveness or Excellence in UK, which actually does this kind of analysis and suggests to the NHS what should be financed through NHS and what should not be financed because it's not cost-effective, or that it's not an optimal use of resources.
So much for your talk today. During your recommendations, you talked about the increased role of the National Rural Health Mission. Did you envision an increased role for the ICDS as well for increasing numbers of Anganwadi workers or Anganwadi centers?
Well, it's already happening. The Supreme Court of India, as you know, had decreed that the ICDS scheme should be made universal across India. The ICDS scheme's limitation, of course, was that it was covering age of 3+, the preschoolers, but from the age of 3+. There was great neglect of the 0 to 3, particularly of the 0 to 2. Now, it's very clearly recognized that if malnutrition is established or sets in that age, it's very difficult to correct some of the effects of that malnutrition later on. So now the second Anganwadi worker has been sanctioned in order to ensure that there is a greater coverage of that particular segment as well, with outreach to the home rather than just limited to the Anganwadi facility. There is also a second auxiliary nurse midwife coming in already. We are suggesting that the number of ASHAs also be doubled, so that the village level team actually really expands and takes care of all of these services. So some of the features of the ICDS scheme are being modified to enhance outreach as well as effectiveness.
For the talk, Dr. Reddy. I really enjoyed it. It was very helpful to see you talk about how you're going to sell this program to the government of India. It was interesting for me when you said that you needed everybody to be invested in this, even the urban rich. How do you see this panning out? I don't see that very viable in the sense that the rural are totally, as you said, marginalized and nobody really includes them.
Pardon me, I didn't get the last part of the question.
How do you see the rich or the urban rich being invested in this? It being a democracy, everybody has to buy into this program.
See, the rural, the rich who are disinterested will not be brought in screaming and kicking into the scheme. They're paying their taxes anyway, hopefully. So that tax money is what's going into the whole scheme, funding of the scheme anyway. But let me put it this way. Those who wish to opt out of the scheme can always access hospitals which are not part of the system. They can pay out of their pocket, get whatever services they want to. But if they ever want to access the scheme, they'll not be denied because they're entitled to the privilege of any other citizen. If Mr. Mukesh Ambani doesn't want to go to the hospital under the scheme and wants to go to some other hospital, he's most welcome too. But God forbid, if he has a minor car accident on the road and wants to go to the nearest public facility, then he will get treated there.
It's going to be the opportunity during the reception to greet Dr. Reddy and ask further questions or continue the discussion. I'd just like to point out for us all that we've enjoyed a truly global experience in the sense of global being all-encompassing. In an extremely short period of time, Professor Reddy has taken us from a complete review of the health status of one of the world's largest or second largest country, maybe the largest now, and then proceeded to place it in context with countries across the world, explain the current status of its health system, suggested where there were flaws and rooms for improvement, presented the remedies for those flaws and improvement, and that's in a real program, not one that's theoretical on his part, but one that's being taken seriously by the government and hopefully will be put in place. And then all of this is utterly relevant to our own healthcare system in this country. The slide Professor Reddy put up of where the opposition will come from for this plan, line by line, can be applied right here. So it's the perfect example of the reciprocity and cross-cultural, cross-national value of global health undertakings, which, as I said, Professor Reddy personifies. So let's thank him again for a magnificent talk. And please all join us outside for some refreshments.
The preceding program is copyrighted by Emory University.